Good morning, doctor.
My name is Dr. Mashhood, one of the doctors here.
My name is Alphonse. I'll be your facilitator for this medical testing. Okay, and this will be your scenario. You are working in an emergency department when a drowsy 28-year-old man is brought in by paramedics. You are concerned about a drug overdose.
Sure. So just to summarize, he's a 28-year-old man brought in by paramedics with suspected drug overdose, right?
Exactly.
Okay. Is it safe to approach?
You are.
Okay, I'm going to wear my own PPE. I will wear gloves, face shield and gown. Hello sir, how are you? Any verbal response?
It's just mumbling and moaning.
Okay, so I'm going to start off my primary assessment. Is the airway patent? Can I see any?
We can hear sound. The sound like a snoring sound.
Snoring sound. So that means there's some partial airway obstruction. I will do head tilt chin left. Does it help with the?
That's clear now.
Okay, so that means I will need some adjuncts. So I will think about either using nasopharyngeal or oropharyngeal airway just to help with the support, okay? And I will also put oxygen on. I will connect to 15 liters non-breather. I've got an oropharyngeal. I will measure it from the tip of the lip up till the angle of the jaw. This looks appropriate size. I will insert it anti-clockwise and just turn it round halfway so it sits into the oral cavity. After this, I will, because I've done the intervention, I will just reassess if it's sorted the problem. Do we have any snoring noises now?
It's gone.
It's gone. So after that, I will connect the patient to high flow oxygen, connect it to non-rebreather mask, connect to 15 liters oxygen, and I will also like to have some oxygen saturation monitoring on at this point.
Yeah, on the monitor it's 97%.
97%. Now I will go down to breathing. I will check the trachea. Is the trachea central?
It is.
Okay. And is the chest moving bilaterally?
It is shallow, but it's moving.
It's moving. And what is the respiratory rate, sir?
Our rate is about 8 to 10.
Okay, so I am worried about his respiratory rate of 8 to 10. Possibly could be opiate toxicity because he's got his respiratory is quite low. So I'm going to think about some medications such as naloxone or Narcan to counteract it. Now I'm going to go down to C. I'm just going to check the capillary fill time. I'm going to press 1, 2, 3, 4, 5.
Top refill is more than 2 seconds.
More than 2 seconds, so it's slightly,
24.
it's delayed, okay? And can I feel a peripheral pulse?
Pulse is weak
And what is the rate?
and slow.
It's slow. And I would like to connect to the monitor because the pulse is slow. Okay, at this point I would like to get a cannula inserted. I would like bloods to be sent off like CBC, urea and creatinine, coagulopathy, a VBG, and toxicology screen including paracetamol and salicylate level. And the heart rate is low, he's bradycardic. I would like to connect a fluid, a warm fluid, around about 500 ml of normal saline.
Right.
In the meantime, I will continue my D assessment. I will look for neurological deficit. Pupils, what is the pupil size?
It's restricted to light.
But it's restricted.
Yeah.
So again, restricted pupils goes with opiate toxicity. I would ask the nurse to get me 400 micrograms or 0.4 milligrams of Narcan or naloxone for this. And 500 ml of normal saline is going through. I would also like to get an ECG at this point to look at QTC and QRS complexes. It looks like bradycardia on ECG monitoring, which could be another sign of toxicity. GCS is the
Still unresponsive.
unresponsive. So if GCS is low, it responds to pain.
No.
So it is less than 8. If it doesn't respond to pain, I would think about putting a definite airway in. I would like to call ICU anesthesia team to get a definite airway. Exposure, I will expose the patient. Any rashes
No.
or any, what's
No
his
trauma.
no strong. And what's his temperature like? Is it cold to touch?
It's 37.
37. So he is normothermic. Now, I would like to give 400 micrograms of Narcan naloxone because of few things, because he's got restrictive pupils, his respiratory rate is low, So I would like to do that. What is blood pressure?
Blood pressure is 88/68.
So he's hypotensive as well, and with bradycardia, I would like to give 0.5 milligrams of atropine, please.
Okay.
And
You prepare and given one dose of 0.5.
And did it make any difference to the bradycardia?
Now,
Okay. And if it
saturation is still maintaining to 96%.
Sure. After 0.5 of atropine, because bradycardia is still persistent, I would like to repeat the dose again,
Alright.
0.5 milligrams, up to 3 milligrams in total.
Very good.
After 3 milligrams of atropine in total, any change of rhythm?
Yeah. Well, preparing for that.
Okay. And I would also like to give Narcan and normal saline. I would like to continue my ABCD assessment again. Okay. So there seems to be a rhythm change on the monitor. Looks like a VF. I'm going to assess the patient, feel the pulse for 10 seconds and look at the breathing. Is there any pulse?
There's none.
So there's no pulse. So patient's gone into cardiac arrest. Please can we activate code blue or cardiac arrest code. In the meantime, I'm going to start chest compressions. 2, 3, 4, 5. I'm going to do compressions at a rate of 30 with 2 ventilations.
Okay, I will help you here.
Okay.
I'm here to help you.
Yes, if you can just give 2 ventilatory breaths.
Okay.
Okay.
That.
Okay, after 30. 2, 3,
Would you like
4.
to do something
Yeah,
about
and
this?
please, can you charge to 200 joules,
Okay.
please?
Charging at 20 joules.
Joules, please. And I will carry on the chest compressions.
Alright.
So once the charge is being charged, I will
Okay, clear guys?
Okay.
Oxygen clear, very
Shock,
clear.
please.
Second on 3. 1, 2, 3.
After
Delivered.
shock, I will continue chest compressions.
Yeah.
I will carry on for 2 minutes. In the meantime, I will think about giving epinephrine 1 milligram, 1 in 10,000. I will also like to think about 4 H's and 4 T's.
Okay, 2 minutes passed.
2 minutes pass, I'm going to reassess the rhythm. It looks like he's got VF and there's no pulse. Please charge again.
Charging at 20
And
joules.
I will continue chest compressions while the charge is being electricity.
Okay, clear.
Clear.
Second on 3. 1, 2, 3. Oxygen clear.
And shock delivered, and I'm going to go back on the chest. I'm going to continue this for next 2 minutes, think about 5 H's and 5 T's. And I'm also going to prepare amiodarone 300 milligrams.
Haven't given 1 epinephrine yet.
Oh, please give epinephrine. And I've also prepared amiodarone. If it's a third shock, we will give
Epinephrine 1 milligram maybe.
epinephrine just given.
Given in flush.
Excellent. If it's a third shock, we will give amiodarone 300 milligrams.
Preparing for amiodarone 300 milligrams.
So 30, and I'm going to give 2 breaths.
2 minutes passed.
2 minutes pass, and I will stop and reassess. The rhythm is still VF with no pulse, so I'm going to shock, please charge and shock again to 200
Charging at 20
joules.
joules. Clear. Very clear. Oxygen clear. Delivered.
Till shock delivered, and after third shock, can we give amiodarone 300 milligrams, please? IV bolus
Right.
push.
300 milligrams amiodarone.
And after giving, just lift the arm
Given
up.
in flush.
Okay. So 25, 26, 27, 28, 29, 30.
Alright.
Okay. So we're going to carry on for next 2 minutes and see what the rhythm is.
2 minutes passed.
2 minutes passed, and it looks like organized electrical activity. I'm going to feel for the pulse. Is there any pulse?
There is no pulse.
There is no pulse, so patient is in PEA.
Yeah.
Let's continue with chest compressions. And it's probably time for epinephrine, please.
Right.
1 milligram, 1 in 10,000. To be repeated, please.
Epinephrine 1 milligram, 1 is 10,000. IV, given and flush.
Flush. And I'm going to carry on to 30:2. I'm going to push hard and push fast. I'm going to think about 5 H's, such as hypoxia, hypovolemia, hyperkalemia, hypothermia, and hypoglycemia. And I'm going to think about 5 T's, tension pneumothorax, toxins most likely causing this patient.
2 minutes passed.
2 minutes passed, and just reassess. It looks like organized electrical activity. I'm going to just have a feel of the pulse. Is
We have a pulse.
We have a pulse.
Weak.
Pulse. So we have gone into post-resuscitation care. Our patient has achieved loss. I'm going to think about optimizing the patient care. I'm going to reassess with A, Do we need, does he need assistance with
Saturation is 94-95.
Okay, now because he's posterized, I'm going to think about getting a definitive endotracheal tube in,
Okay.
and I will let Lorenzo do that. Breathing wise, is the chest moving bilaterally?
Okay, let's intubate.
Yes,
Let's
yes.
see.
The patient's intubated now, we've got definite airway,
Yeah.
we're going to connect to with our ventilator. We're not going to try to hyperventilate, we will do it at a rate of 1 breath every 6 seconds, total
Okay,
of 10
saturation
breaths.
improved now to 97 to 98.
Excellent. For the breathing, I'm going to make sure, clinically assess, making sure there's no signs of pneumothorax. I will also get a portable chest x-ray. I would like to do a 12-lead ECG post-cardiac arrest.
We have it, yeah.
Okay, I would like to do some new lab work, CBC, UNE,
We'll do it in
DipPH,
Central Lab.
and troponin. I would like
ABG
to,
also.
ABG also, thank you. I would also like to do targeted temperature management between below 30, between 30
Hold
and
it.
36.
Blood pressure is 88.
Okay, for fluids, blood pressure of 88, I would like to give 1 liter of normothera bolus.
Okay.
If that doesn't help, I would like to think about starting.
After 1 liter is still 88.
Okay, then I would like to start some vasopressors, like norepinephrine. I would also like to contact the CCU and the ICU, because patients intubated needs to go to a higher level of care, like in ICU, HDU, CCU care. After this, I would also like to make sure I'm going to go back and reassess his airway, tubes in the right place, get a portable chest x-ray, wait for the bloods to come back, do an ABG to look at the arterial blood gases.
Yeah.
And they're just going to continue on with the management.
Would you like to call toxicologist?
Yes, I would like to also call the toxicology helpline in case we need to give some antidotes. I've also given naloxone, but maybe there might be some changes on 12-lead ECG. We might have to reverse it. We might have to give sodium bicarbonate.
ICU is ready.
ICU is ready, then move it to. Thank you very much.
Congratulations.